Well, welcome everyone to our week 6 of the Project ECHO Introduction to Palliative Care for Humanitarian Health Workers with a specific focus on East Africa. We're really glad you're with us today. We've had a chance to introduce some people before we started recording, which is great. But please feel free to put your name and where you're working in the chat. One of the really nice things of this program is that we have representation from many countries in East Africa, West Africa, and as well as Europe and North America. So please don't hesitate to put your name and where you're working and what you're doing in the chat. We would love to get to know you. So we are on week 6. My name is Erin, and I am the coordinator for this program. I'm a palliative care nurse working in Nairobi, Kenya. And I'm really excited about the topic for this week. We are going to be looking at how to provide palliative care for children, especially in vulnerable settings and humanitarian responses. And we're really honored to have 2 great speakers with us today. We have Professor Julia Downing. She's the chief executive at ICPCN, which is the International Children's Palliative Care Network. And they are representing many people that are providing palliative care for children around the world. So really excited that she's with us today. She has a lot of experience working in East Africa, so I think some of you might know her well already. But she's going to be teaching us on the topic of children's palliative care today. She will do her session for about 20 to 25 minutes, and then we will move into a time of discussion where we'll talk and answer some questions that you have on the topics or the content that she's sharing. And then we'll move into our case discussion. Esther Beatty is a nurse from Canada that is working in Senegal, and she'll be presenting a case that we hope to be able to have lots of discussion and learn from as well. And it will be a children's palliative care case for today. We're aiming for the call to be about 1.5 hours. If you do need to go, please make sure you wait until I share the attendance list. We would love for you to get on the attendance for today. So please look out for that. I will share it shortly after the 1 hour mark. And yes, if you have any questions, don't hesitate to put it in the chat. Please do remain muted if you can. We love to see your faces. I know a few people are able to do their video. If you can't, that's okay. But yes, we love to be interactive in this session. And I will hand it over to you, Professor Julia. Thank you.
Thank you very much. And it's great to be here today. Can you see my screen okay?
Yep, looks great.
Yeah. Great. So it's great to be with you all today, and looking in the chat, some of you are from Uganda, from Kenya, from Ghana, from Senegal, from all over. And as Erin said, my name is Julia. I'm the Chief Executive of the International Children's Palliative Care Network, but I'm also an honorary professor at Makerere University, and I've been living and working in Uganda for over 20 years. And I'll be here to present to you, but then unfortunately I have to leave as I am transitioning back from the UK to Uganda, so I need to go to the airport. So I might see some of you back in Uganda soon. So I'm going to talk to you about providing palliative care for children in vulnerable, fragile and conflict-affected settings. Now, also just to say that you are the first people to see a presentation with our new branding. Literally half an hour ago, our new website and our new logo were launched. So this is new for us. So this is our new look, and I would encourage you to go and look at our new website later on today. So we're going to be talking about providing palliative care for children. And it's such an important topic. These are 2 little children from Kenya who had HIV, I believe, and they were accessing palliative care. And we were able to make a big difference in their lives in the last few weeks and months, which enabled them to have a good quality, or as good a quality life as they were able to. And that's why we do this. That's why we want to improve the care for children needing palliative care around the world, and in different settings, including in vulnerable, fragile and conflict affected settings. So we're going to look at children's palliative care. We're going to look at what are some of the things that can improve the quality of life for children and their families. So some of the principles of children's palliative care, how we integrate it into our care, and then some of the challenges that we might be facing. So it's always good to start off with the definition of palliative care for children. And this is from the World Health Organization. And they clearly state that it's the active total care of the child's body, mind and spirit. I love that because it's about the whole child. It's also saying that it's active care. It's not a matter of there's nothing else we can do. We can make a difference to their lives. It begins when illness is diagnosed, and that's something for us. I think sometimes it even begins prior to diagnosis. Many of our children, particularly in vulnerable settings, might never get a diagnosis, maybe because they have presented late, maybe because they can't afford it, for whatever reason. We need a multidisciplinary approach, and I see from the chat that we have a range of disciplines on the call today. And very importantly, it can be provided when resources are limited, and it's also provided wherever we find the child, whether that's in a refugee settlement, whether it's in a hospital, whether it's in a school or at home. We can provide palliative care. I think some key features that are really important for us to think about is that it is not limited to the last few days and weeks of life. It's not just about end of life care, but across that whole spectrum. We can provide it alongside treatment to control disease. They might have chemotherapy, but we can also be providing palliative care. We're trying to improve or maintain quality of life. It's about holistic care. Another myth is that it's just for children with cancer, but it's not. It's for any child with a life-limiting or life-threatening condition. It requires active care. We are actively caring for the child and their family, and we need the multidisciplinary team. So let's just have a think, and perhaps you can put in the chat box here, when is the best time for us to begin providing palliative care for a child with a life-threatening disease? And hopefully you will have picked that up already from what I've said so far. But here are 4 options. When there are no more curative treatment options, when the child has less than 6 months to live, when the family can no longer afford treatment, or when the child is diagnosed with a life-threatening or life-limiting condition. Which of those is the best time for us to start providing palliative care for the child? And just put a number in or a letter. Yep, we can see people putting in the chat box. And great to see that everybody is saying D, when that child is diagnosed with a life-limiting condition. And this is confirmed not just by the World Health Organization definition, but also by the American Academy of Pediatrics, who say it should be offered at diagnosis and continued throughout the course of illness, whether the outcome ends in cure or death. It's provided alongside treatments that might cure the child. So there are various myths, and we've touched on some of these before. I think one of the key things is we know from families that they find it really hard if we say there's nothing more that can be done. We might no longer be able to cure a child, but we can still do things. We can still provide care. If you say there's nothing more that we can do, parents feel that we are giving up. We feel that we have failed. And there's always something that we can do to help support the child and that family, even when cure is not possible. Another myth is that it's only available when there is no disease-directed care, so if cure isn't possible. Some people believe if you start palliative care, you are bringing the child's death sooner. Some people believe it must, so that should say must be given at hospital, or it must be given in the home, but it can be given wherever the child is. And also, unfortunately, some people think that you can't provide palliative care for a child in a humanitarian setting, but we know that you can, and that this is feasible. This is what's called the bow tie model, and it shows that right from the start of diagnosis or before diagnosis, right through the continuum of care, you can be providing palliative care. Now, the amount of palliative care compared to care aimed at managing the disease or curing the disease will vary as you go from diagnosis through treatment and then into end-of-life care. But the two can importantly be given together. And I like this picture because it demonstrates that so clearly. So who do we provide palliative care for? Which children need palliative care? Well, children living with a progressive condition, a condition with ongoing deterioration of health and or abilities, children with a life-threatening or a life-limiting condition, but also children with significant pain or with other symptoms which palliative care can address. And we often, in low-resource settings, and particularly in humanitarian and fragile settings, get asked to see children with symptoms that need some help that we can support managing, but who might not necessarily have a life-threatening or life-limiting condition. But we can support them and help to manage their symptoms, their pain, or whatever their symptoms might be. So in the Global Atlas of Palliative Care, it shows a wide range of children needing palliative care. You can see nearly 30% had HIV disease, over 30% have premature birth or birth trauma or congenital malformations. And then there's a wide range of other conditions. Protein energy malnutrition is a key one for us working in humanitarian and fragile settings, but a wide range of other conditions, organ failure, heart disease, neurological disease, and cancers. So a wide range. Now, this slide isn't very clear, but hopefully you'll get to the feel that there's some work that's been done by Together for Short Lives, and they came up with 4 categories of children that need palliative care. Category 1 is those with a life-threatening condition for which curative treatment may be feasible, but it can fail. So that is cancers and many of the organ failures. Conditions where premature death is inevitable, such as with Duchenne's muscular dystrophy, cystic fibrosis. Progressive conditions without curative treatment options, and then irreversible but non-progressive conditions which might cause severe disability, which will then lead to susceptibility to health complications and likelihood of premature death. And this is particularly the case within many humanitarian settings. There's also been talk about adding other categories around perinatal and neonatal palliative care and caring for bereaved children. So we can see that there is a wide range of children needing palliative care. Now, in the humanitarian settings, this is an example that Dr. Megan Doherty talked about, 11-month-old child who had bilateral club feet. And he was actually referred to palliative care within the refugee settlement because he was disabled. The mother was living alone with 3 children. And what actually happened was that the palliative care team were then able to get him onto an orthopedic program. They were able to support appointments and childcare. They were able to support follow-up. And I think he was then able to have surgery. So this is not your typical palliative care case, but as I've said, within humanitarian settings, we often see a wider range of children. And one of the key things that we talk about in children's palliative care is hoping for the best, but planning for the worst. So with a child with cancer, we are hoping that the chemotherapy will cure that child, but we're planning for the fact that it might not. And what do we need to do in that situation? And using these phrases can be really helpful when talking to families. So just to share some of the principles of palliative care in children. Firstly, it's across the continuum of care, and we've mentioned that already, from diagnosis or before diagnosis through to death and into bereavement. It's across the variety of care settings. Wherever we find the child and their family, that is where we should be providing palliative care, whenever they will benefit from it. And I think really importantly, palliative care should not be seen as a last resort, but as an essential component of care. Now, the environments that we work in are very different, but in some oncology units, for example, every child that has a diagnosis of cancer will also see somebody from the palliative care team, so that it becomes a normal part of the care for that child. So it's important that palliative care is not seen as a last resort. It's not about giving up. It's an essential part of the care we provide and can improve quality of life. And we've talked about the place of care. This was a family in a refugee settlement. Wherever that child and the family is, we need to try and provide care. Now, we know that there are not necessarily home care programs. Families might not be able to afford to come into a hospital or to come to see a palliative care nurse. So we need to think about how we provide care. We need to make sure that we involve community volunteers or whoever those people might be within the different settings, and involve the community around the families in the care that we provide. Pain and symptom management is a key part of what we do, but it's not the only part. Another myth is often that palliative care is just about pain. It's not. It's broader than that. We need to look at the psychological, the social, the spiritual, as well as the physical. But pain and symptom management is essential. It's a key part of the care that we provide. It shouldn't just be about the child's condition, but also to treatment as well. What about procedural pain? How many children do we just put needles into without thinking about trying to prevent that pain? It should include pharmacological and non-pharmacological ways of managing pain and different symptoms, and these should be integrated together. It's important right from pre-diagnosis and onwards. If a child experiences a lot of pain when they are going through diagnostic procedures, that memory will stick with them and it will impact the way that they experience pain, not just through that condition, but throughout their life. And as I've said, we need to be thinking about the physical and the psychological components. Emotional support is key for all children, regardless of age. And we know that their different friendship groups is really important. Do they have friendship groups with other children with similar conditions? But then we know that within a fragile setting, within a humanitarian setting, that can be a challenge. But where possible, that is helpful. Emotional support is important for the child, but also their whole family. What about their siblings? What about brothers and sisters? And within the humanitarian settings, what have these children already been going through? Have they been going through war? Have they been going through earthquakes? What is it that is impacting on their lives and the lives of their family? Maybe they've been separated from their parents. So there's so much going on within the fragile and humanitarian settings. And on top of that, we have children with life-limiting and life-threatening conditions. So we need to address that. We need to be open and honest in our communication. And we need to try and encourage families to talk openly amongst themselves, which in many settings is a challenge. Social issues. Well, many of the children we will be caring for in fragile settings will have social issues, and the importance of peer support from other people from within their community. We know that there's a lot of loneliness and isolation. There's stigma and impact on the families. There's an inability for the families to continue with their normal social activities. And for many of the families within the humanitarian setting, they already can't continue with what used to be normal. They now have a new normal. And then on top of that, they have children with life-limiting and life-threatening conditions. We also know that where possible, schooling is important. We've done work in Uganda and other countries asking children what they want and what are their needs. And very key, children want to go to school. They want to feel normal. They want to learn. Again, many in a fragile setting will have been removed from their original schools. Is there opportunity for them to go to school within the context where they are living? And is that going to be possible with a life-limiting and life-threatening condition? Spiritual issues, and again, these link very much into the situation in which the child and their family find themselves. And on top of that, you have the existential issues that are so important to children's palliative care. Something that we often find hard to talk about, and yet sometimes children find it easier to talk about it than their carers. Some of the concepts within children's palliative care, we talk about hope and maintaining hope. So we're hoping for the best, but we're planning for the worst. The meaning of their illness, and we know some of the cultural issues and the cultural beliefs around illness. Connectedness and relatedness, acceptance, key spiritual issues. And we don't just mean religious issues, but thinking about spirituality in the wider context. So end-of-life care is key to palliative care, although it's not the only component of palliative care. So we do need to try and provide support for the child and their family at the end-of-life care, not forgetting the siblings, being very much aware of the context in which they are living, helping them make decisions. And for some of our families in the fragile situations, that is a challenge. Maybe they've been separated from the parents or the father or the decision makers in the family. How do they make those decisions? Some families might have thought about what they want to happen and have an advanced care plan, but we find that that is often not the case within the humanitarian settings. And where are they going to receive the care at the end of life? Grief and bereavement is key. And again, many of the families that we're working with will already be going through a complex grief and bereavement situation, loss of family members, loss of their home. How do we provide support? And as a team, can we support the child and their family? And it is great to have access to bereavement counselling, but many of our families won't have that. And so how can we support them the best that we can? Particularly also with a group who might well be mobile, who might be moving from one refugee settlement to another. So complex issues that we need to be thinking about. We've mentioned communication, and good communication is key. It's also important to be open and honest. We always say it's important never to lie to a child. We need to be building trust, and that can be hard with the population that we're working with in the fragile settings, where trust might well have been broken down, where we might only be seeing children a few days before they die because of the situation in which the families are living. We need to open up communication with their children, their siblings, the families, the health workers, and there are many frameworks that exist and that we can share that can help us in our communication, but good communication is vital within children's palliative care. We've mentioned the family and significant others, and these are key throughout the course of the illness. And within the settings that we're working, this can be so complex. And we need to think about the whole family. And who are the significant others? Maybe due to the situation the families find themselves in, the significant people in that child's life are not related to them. Maybe they're being cared for by other refugees. How do we ensure that the people involved in that child's care are receiving the important information? And then, of course, financial issues. And again, so key for families, how Do they access care? Do they need to pay for medication? How do we support them? Many people, not just in vulnerable, fragile and conflict situations, but many of the people we care for in sub-Saharan Africa will be poor and will have limited finances. How do they manage the cost of being with the child in the hospital or the clinic, the out-of-pocket expenses, and the costs of caring for the child? And we've seen that many families with children with palliative care needs just spiral into poverty due to the costs and due to their lack of finances. So how can we support them, and how can we provide the best care possible in this situation? And importantly, as we mentioned before, we do this as a team. The family and the child are key to the team. They're at the center of the team, but we work with a wide range of people working in humanitarian settings, health professionals, volunteers, teachers, carers, who is involved in that child's care. And we need to be constantly liaising with the volunteers, with the health workers, with the religious leaders, whoever it is who is involved in that child's care. So we can integrate palliative care into vulnerable, fragile and conflict settings for our children. And just as I close, I'll just give a few examples. These are some of the manuals that are available to access in terms of vulnerable, fragile and conflict settings. There are also manuals from the World Health Organization on integrating palliative care and symptom relief into the response, but also to humanitarian settings, but also in pediatrics. There are a wide range of resources, many which you can download on our new website in the resources section. Within the standards, the global standards for pediatric palliative care, there is a section on standards for the provision of children's palliative care in humanitarian emergencies, and these standards can also be downloaded from our website. But it re-emphasizes the importance of providing pediatric palliative care within the humanitarian response, and to make sure that staff working in humanitarian settings are trained and have the necessary skills and knowledge. So training such as this one is so important. But we know that there are many challenges in the provision of children's palliative care. There is often a lack of recognition of the need for palliative care. And one of the things in humanitarian settings, particularly in acute settings, is that acute need for providing care, and palliative care might not be seen as important in that acute initial phase of care. But as we go on, the importance of palliative care is seen. There has been a lack of policy on provision of palliative care in humanitarian settings and generally, but we know that MSF are including palliative care and children's palliative care in their response, the Sphere Handbook. There is much more recognition of the need for children's palliative care, but it does need to be integrated into the healthcare we provide within these settings. For many, there's been a lack of access to education, treatment, trained health professionals, a fear of the use of opioids, a lack of resources. How do we make decisions when perhaps all the decision makers in the family aren't there? It's a mobile population. They might not have any medical or health records. Palliative care isn't seen as a priority. We need a wide variety of models of care. And there is a lack of understanding of the need for children's palliative care. Plus, we are trying to provide children's palliative care in a setting and to people who are already traumatized. They have many fears and many emotional issues related to the situation they're in. They find it hard to trust people. Providing death and bereavement support is complex, and it can be hard if we want to try and work with them to try and make some memories of their children. So we know there are challenges, but palliative care can be provided for children within humanitarian settings. And I'm sure you've already seen this picture, but one of the challenges is the lack of access to medicines. And this here shows the morphine equivalent usage across the world. And you can see that in many of the places where we work, the countries have disappeared because access to medicines such as strong analgesics can be challenging, even more so in humanitarian settings. So to close, what are our goals in providing children's palliative care in vulnerable, fragile and conflict situations? Well, we want to help the children and their families to achieve the best possible quality of life, recognizing the situation that they're in. We want to try and relieve their suffering as much as possible. We want to care for them with competence and compassion. And we want to respectfully accompany the child and their family on their journey. That journey might be through into end-of-life care and into death and bereavement. It might be into survivorship. We might just be accompanying them on part of their journey as they move from one humanitarian setting or one refugee settlement to another. But whatever we do it with compassion. We want to do it respectfully. We do it with competency. We do it in order to relieve their suffering and improve the quality of life as much as we possibly can. So that's the end of our presentation. If you do go to the ICPCN website and the resource section, you will find many resources there on children's palliative care. And I will be sending the PDF version to Erin. So I hope that that was helpful.
Thank you so much, Julia. I know we've given you a pretty impossible task to share all that in a short amount of time, and I know you have to head out, but what are some people's initial thoughts and comments on this? Is this maybe the first time you've thought about providing palliative care to a child? Or are you on the other spectrum where you take care of children that are very sick with very limited access to care and treatments on a regular basis? Where do you fit in? And if anyone has any particular question, Julia, I'm sure has a few more minutes, maybe 5 minutes, we can take some questions. You're also welcome to put them in the chat. I know Estella is calling in from Burundi. Did you want to ask a question to Professor Julia?
No question, but I want to thank her, but it was very interesting.
Mm-hmm.
Yes.
I see somebody's mentioned about nutrition, and yes, nutrition is important. Within the care that we provide, good nutrition is always important, and that can be a challenge within the humanitarian setting. There's so much that is important. I can't mention everything within 20 minutes. But it's about, if you just think about the whole child, then obviously nutrition is key. If we're looking at the physical, the psychological, the social, and the spiritual, nutrition is key. So is play. Play is an important way that children can express themselves. So there's so much we can say in the provision of palliative care for children.
Yeah, I know there was an example of a home-based care program that was doing palliative care in a really limited resource setting, and part of their home-based care program was also to provide food. Yeah, I mean, as you're thinking about programming in your setting, what are some other even NGOs that we could get incorporated into the support of these children? I think the example was the doctor told the family to give the medication after the child took food, and they never had food, so they never gave the medicine. So I think sometimes in these situations, even those basic necessities are really important. Of course, they're really important for everyone in the family, but even more so important for a child if they're sick.
I'm really sorry, Erin, I'm going to have to go.
Yeah, no problem. No, it's great.
Get my flight. I'm just putting our website in the chat, so if people want to
great.
have a look.
Yeah, and we're looking forward to hearing more about the logo and how that all came to be. But next time.
Yeah. Good to see
you
all.
Later.
There's quite a few people that I recognize, so good to see you all. Thanks.
And Julia is one of our regular faculty. So if you wanted to reach out to her, she's usually reachable by email. And I think she had shared that. I can also share it on the chat. Well, I think that has prepared us all, or at least got us into the right frame of mind as we go into this case. Children's palliative care is a challenging area, and we know that you at the front line are also doing really challenging work. So part of this ECHO program is that we want you to know that you're not alone. We have about 60 people on the call today. We have several more on our WhatsApp group. This is a group where we're trying to foster community. So if you do feel like you sometimes are taking care of children in very difficult situations, please reach out. People like Ali are around, of course, myself and Esther, and the rest of the faculty are here to help. So I won't take any more time because we do have a really complex case. But please remember your pen, your pencil. If you wanted to make notes, please have that here. And Esther, I'll pass it over to you. Esther is one of our new faculties on the call. She's experienced nurse in palliative care in Senegal, and she's currently living in Canada, but continues to support work in West Africa. So welcome.
Thanks, Erin. And that was a great presentation. And this is my first time, I'm just going to say, facilitating a case study. So just bear with me. I think all of us, when we think about palliative care, especially for children, it touches all of us in our heart. It's not something that we can just think about, but it's actually something that's very touches our heart. So this case is a case that, let me just go there and see if I can do that. So this case that we're sharing today is a complex case, just giving you a little bit of the background. And it's a case that took place in Bangladesh. And it was in an area where MSF worked. So there was a bit of a hospital setup as well as a palliative care team. So I know for most of you on the call, you might not have those resources, but I think as you see us go on in the case, you'll see that there's a lot of things that we can all relate to.
Okay, this one.
But, sorry. Sorry, Erin. Everyone.
No problem. If you click, it says use slideshow at the.
Can you see, can everyone see the screen right now where it says treatment timeline?
Yeah, but try to do it into full screen.
Okay.
Can you click use slideshow? There's an option beside tips in the top left.
Yeah. Okay.
Device is doing this.
Yeah, if you click on that one,
Sorry.
that's okay. Or end, there you go. Perfect.
Okay. So there we are. All right. So is that the next one? Okay, so I gave you a bit of a background on the case. So the case, here's some questions. No, it's not going to my next one. These are some questions for us to think about as we're listening to the case. So what is the best approach to managing an acute deterioration in a child with an incurable condition? So just think about some of the children that you see that are diagnosed with something that cannot be cured. How can we manage this child's breathlessness when we don't have morphine? How can we support the family when they want to take a child home? And we know this child in this case needs oxygen. So how do we support a family when they want to take the child home and there are no resources in the home? And what is the best approach that we can use when a family wants to see a traditional healer? Most of us work in areas where families will probably want to, if they haven't already taken their baby or their child to a traditional healing, it will be very important to them to have a traditional healer involved. And what are other suggestions that you can think of to improve care for this child and family? And you can, at the end of the case, you can either unmute or you can put your thoughts in the chat. So the background for this, I'll just wait. So this is a case about a 5-month-old girl, baby girl, who has congenital heart disease. The case took place in April of 2021. So the child had severe breathlessness, and the family had been running around trying to find places where they could get treatment for their baby. So April 24th, the child was admitted with respiratory distress. And it was very clear that this baby was in respiratory distress with chest indrawing, wheezing. And in the facility where they were admitted, there was oxygen. So the baby was started on oxygen, 10 liters, and was given medications of ceftriaxone, dexamethasone, salbutamol, and also some IV maintenance fluid because the baby was also malnourished, as you can imagine. By April 28th, the baby's condition was slowly improving. So that's 4 days later. And the team was able to wean from the 10 liters to the 2 liters by nasal cannula, but the baby was still showing the signs of respiratory distress. And at this time, they did an ultrasound and they confirmed that the baby had a congenital heart defect. And so the heart defect was where the 2 major arteries that connect to the heart ventricles, they were actually reversed. So the aorta was attached to the right ventricle instead of the left, and the pulmonary artery was attached to the left side. So this is a condition that we know can only be cured by open heart surgery. So that was what the team discovered when they did their tests. And they were also just, by the 4th day, they were able to start feeding the baby with a nasogastric tube, and they were slowly increasing it. So the baby looked like she was improving. By May 4th, the baby was sleeping, opening their eyes, seemed to still be in distress, but the condition was improving. The family actually wanted to take the baby home. The mother was there with the grandparents, the father wasn't there, but they wanted to take the family home. But it was explained to them that the baby, actually, they were hoping to get morphine to help with the breathlessness. And also that since the baby was still on oxygen, so the family agreed to stay in the facility, waiting for the morphine to arrive. And they had a difficult talk with the family about whether or not they could resuscitate the baby if something happened. And they weren't sure how long the baby would live, but it was, they agreed that they would not try to resuscitate this baby. So unfortunately, 4 days later, there was a deterioration again. The baby developed a fever and went into more severe respiratory distress. And at this time, the team thought this was probably reversible septic shock. So they continued to give fluid boluses and IV antibiotics, and they had to increase the oxygen back up to 14 liters. May 6th, so a couple of days later, the baby developed phlebitis, so it was very difficult. Maybe just wait, maybe I'm on a wrong slide. So on day 6, the morphine still wasn't there. And I think we talked about this last week. What do we do when there isn't any morphine? They did have access to tramadol IV. So they started the baby on some tramadol, not noticing any significant improvement. And they were leaving the oxygen in place, but they weren't going to increase it. The baby had a tonic convulsion that lasted about 3 minutes. And unfortunately, there wasn't any medication given. So the plan was from now on, if the baby had more convulsions, they would aggressively treat the baby with diazepam. By day 8, the baby was only reacting to painful stimuli. By May 9th, the baby was discharged with the family. So this is the treatment timeline. We're now going to go into the pain and symptoms. So the main concern from the mother was the baby's breathlessness, and they tried to use tramadol 0.5 milligrams per kilogram per dose every 6 hours, increased it. They considered diazepam for this baby, especially since the baby had the seizure, but they never gave any. And they did positioning and chest physiotherapy. With the fever, after the deterioration on May 4th, there was persistent fever, so they gave scheduled paracetamol and ibuprofen. With the irritability and agitation, they were thinking about diazepam, but it was not given. And also for the convulsions. The baby had developed some skin breakdown from the diarrhea. And so they were questioning whether or not there was pain, and they were using skincare and again using paracetamol and ibuprofen. So the nursing issues I mentioned, the child developed IV phlebitis, so it was becoming more and more difficult to start an IV. And as I mentioned, the child began to develop skin breakdown because of the loose stools. So there is frequent hygiene, a little improvement with the skin integrity. The mother and the grandparents, as I said, were involved. The father wasn't there, and this was a refugee family. The primary questions and concerns were the breathlessness. Also, what caused this? Why isn't the baby getting better? And why aren't we sending this baby somewhere else? So it was very difficult for the mother to understand what was going on. And also they were wondering why we couldn't send the baby somewhere else for surgery, maybe give them the finances that they would need to send the baby somewhere else for the surgery. The psychosocial, as we can all imagine, the mother was very, very shocked. And initially the family wanted to go home, but they agreed to stay because they knew they couldn't get the oxygen or the medications for the baby at home. The day of discharge, as you can imagine, was also very difficult, but they had other children at home. They wanted to go home. And also this was a family of the Muslim faith, and it was just a short period of time before the festival of Eid. They were able to have 3 sessions with a mental health counselor. They had daily visits by a palliative care coordinator. And also the watchman was waiting to allow visitors, so he knew about the situation. So as I mentioned, the spiritual concerns, the family did want to visit a traditional healer. So the unit agreed to have one of the traditional healers come to the unit with the agreement that he would not give anything orally to the child. So the traditional healer was able to recite some Quranic verses over the baby to hopefully bring spiritual healing to the baby. And as I mentioned, the baby was discharged just before Eid, and that's a very important celebration for families to be together. The communication. So how much did the patient's family understand and know about what was happening with this baby? The prognosis was shared with the family at the very beginning, that they thought this baby was probably not going to get better. There was counseling, mental health, palliative care, and again, the family wanted to go home, but after learning a bit more, and they did have some local speaking people, as well as they were using diagrams to try to explain what was happening to the baby. So they did understand, and they had an interdisciplinary family team. So as you can see, there were a lot of different players on the team for this baby's health. And initially the family didn't want to stay, but they understood. And it wasn't something that could only be explained one time. As you can imagine, this family was probably in shock, and they needed to hear it over and over again. And it was very difficult because they were asking for referrals and to maybe have the baby sent somewhere to have the expensive surgery. So as I mentioned, there were a lot of different members in the care team. as you see. And again, they were thinking about sending them home, but the baby was oxygen dependent. So the summary, as we saw, is a 5-month-old baby girl with a heart defect, a congenital heart defect. The primary concerns were breathlessness, the oxygen dependency, and the family's desire to go home. And this case was complicated because they didn't have morphine. They were waiting for the morphine prescription to get filled in the capital, but it didn't arrive. The baby unfortunately developed septic shock on day 11 of admission. So here are some questions that you can answer. What is the best approach to managing a deterioration in a baby or a child with an incurable condition? If anybody has something, an answer.
Yeah, Esther, we could maybe take them one by one because I think these are really good questions.
That's what I was thinking, yeah.
Yeah.
So I'll just stay on that one.
Yeah, perfect. So you're welcome to put in the chat.
What can you do? What can you do if you had somebody come and you know that there's nothing, that this is a surgery, but you don't have the resources to do the surgery? Erin, are you going to watch the chat for me?
Yeah, I can for sure.
Okay.
Leah?
Do you want me to try and reset that?
No, I can go into the chat.
Ali, did you want to share what you've done in the past?
I can reset your shares.
No, it's okay.
Ali, do you want to go ahead?
Hello.
Yeah, welcome. Yep.
Good afternoon, Erin.
Yeah.
I hope we are discussing about this case, the question. What is the best approach
Yeah.
to
What are
managing
your
an
thoughts?
acute traditional child with an accurate condition? I
Mhm.
think in this situation, I think we need to use also a spec. The spec, the setting when you are attending such clients, the environment of the patient, and where we are handling. I think the best way we can use is that the spec method.
For delivering bad news.
Yeah.
Yeah.
But what
Yeah.
do we do when we actually have a child who comes to us with something that we know we can't fix? We can't fix it, but we might be able to make it better. Is there anybody else that has? Yeah, the spike approach would be for communicating. So managing symptoms. So that would be important for us to focus on managing symptoms. What do we have and what can we do? For example, if we do have oxygen, we can use oxygen. And also we were seeing they didn't have the morphine, but they had tramadol. So they were able to give the baby some IV tramadol.
I think in situations like this, if you guys are finding yourselves with a child or any patient that the symptoms are very complex, I don't think it's a bad thing to have a telephone referral to a consultant or someone that you can reach out to in your organization that might be more senior than you are and can give telephone advice. They wouldn't necessarily take over care. You still are obviously the primary caregiver, but they may have, or care provider, sorry, but they may have advice that you might not have talked about because of the intensity of the case and you're in the middle of it and things are deteriorating fairly quickly and all the communication that's required. I think it's really important that we do reach out to colleagues or yeah, whoever is in your line of consultation. I think it's really important.
Thanks. I'm going to go on to the next question, but you can continue to put your comments in the chat. My next question is coming on. How could we better manage this child's breathlessness since we didn't have morphine? So what can we do if morphine's not available? And this might be non-pharmacological. So what kind of actions can we do to care for this child?
Once again, I think this question, how could we better manage this child's breathlessness since morphine was not available at the time? What about tramadol? Is tramadol still available?
Yeah, I think they used tramadol, but there was little effect. But yeah, it's still
I think we can use. I think we can also do this process non-pharmacological. I think we can do CRB, CPR, cardiopulmonary resuscitation.
Yeah, so the patient still had a heartbeat, so we wouldn't necessarily need to do CPR, but I think some of the things we were talking about last week, do you remember the different things that we were talking about related to breathlessness? Sometimes repositioning a patient so they have easier ability to breathe, using a fan, making sure I'm not sure what kind of hospital room they were in, but if there's a better airflow, the child may also experience some relief.
Yeah.
Edna had some good thoughts, Esther. Play therapy, distraction, propping the child up, making sure that in a family meeting that the family does know that they are dependent on oxygen, but you know, having people visit, I think, is important.
And it's important for us to have that attitude that we may be overwhelmed because we don't have what we need to really manage this, but it's important for us to show that we can still care and contribute to this child's comfort by doing these things like the fan, the window open. And that's a challenge, I know, when we feel like we could do better if we only had more. The next family, how could we have supported this preference to take the child home?
Yeah, so this is a really interesting situation, and I would really love to hear from the group. When this happens in your setting, how do you approach these situations when families want to go home? How do you counsel them through that? How do you support them?
I think in this situation, how could we have supported this family's reference child home given a dependence on oxygen?
Yeah.
I think this one we could in this process it needs good communication skills that we can talk to the family about the oxygen. Mostly oxygen therapy is available at the hospitals. At the home level, it's not available.
Yeah.
I think we can advise them in a good manner, in a good communications, so that they attend to the hospital. The child will be taken to the hospital as soon as possible for oxygen therapy. I think that's the key. The key is the good communication skills.
Yeah, it seemed interesting on this team. It seemed like they were able to work with the family because of the extra counseling support that the healthcare facility was able to provide. But in general, it is really interesting when a family has a preference. What do? We can't necessarily judge them. We need to make sure we give them sound medical advice. So it sounded like the MSF team in this situation were able to convince the family to stay for a few more days, to be able to identify if there was more that they could do for the child. But then ultimately they did. Wasn't that the result in the situation, Esther? They did take the child home.
They did take the child home. Yeah, in the end, they did take the child home.
So I think especially for our oxygen dependent patients that are going home without oxygen, we need to be fairly clear with an educated family member or whoever seems to be the primary caregiver that when these situations happen, the amount of time that they will have once they are not on oxygen is very limited. So we need to be able to find a way, culturally sensitive way, to share with the main decision maker or whoever that is. It may not be the mother, it might be the father, it might be the mother, but they need to understand that it could be a few hours. I mean, it may be a day, but it may not. If someone is extremely oxygen dependent, they will not be able to manage for very long. And I think the idea that for this family, they wanted to be home for Eid, which was 2 days away, the baby may have died before that. So I think it's important that although it's hard to talk about that for a 5-month-old child, it is still something that's part of our duty as healthcare providers, that when people leave, they do know to the best of our ability what we anticipate will happen.
Yeah, and Erin, I just want to add that from my limited experience working in a Muslim context, people seem to be more accepting at times of death than we are.
Yeah.
So I think that that's something as healthcare providers, we need to be careful that we're not putting our values on somebody else. So if it's the most important thing for a family to have their child at home and they understand, I think the understanding thing is key, that we can explain that, especially in this situation, it's possible that the baby would die on the way home. But you can't stop a family from doing that. And I know for me, I've had situations where I felt extremely sad, but it seems to me that the family is understanding that this is what God's will is for this child. So sometimes they're actually comforting me as the provider. Maybe going on to the last question there, I think it's the last one. What is the best approach when a family requests to see a traditional healer? I'm not sure in the context where everyone works if they've had these kinds of issues. I know in Senegal, often families will go to traditional healers before they come to a medical facility, but what do we do? What do people do? And one thing we didn't mention is that I think often in some of our situations, people's understanding of illness usually includes some kind of a spiritual focus. So as we saw in this one as well, that the traditional healer came. But yeah, what do people on the call do? How have you dealt with this kind of issue? Okay, so I see someone let them go to the traditional healers.
I think that the team at MSF seemed to have taken a fairly diplomatic approach where they wanted to include and respect the values of the family by inviting the traditional healer to the hospital, but also sharing just some of the limitations that for this child, because the child was quite sick and suffering with severe breathlessness, I think they had suggested that nothing should be given by mouth. So
yeah, that's what I was going to say. I worked with a doctor in Senegal who said that he would always tell the families not to hide from him if that's what they were doing, if they were taking the family member, and that he would be willing to go along with whatever it was as long as it wasn't something oral that the person had to ingest that could be dangerous. Did you want to say something, Ali?
Yeah, what is the best approach when a family requests to see a traditional healer? I think in this scenario, a child who needs oxygen, who needs urgent referral, or maybe in the hospital is an oxygen therapy. And the family request for wants to see a traditional healer. I think this is very difficult. I think it's good more of counseling to the clients, to the family, the caretakers about that the child is on therapy of oxygen, and traditional healers cannot do and give oxygen to the child in this condition. I think it's a bit I think it's a bit hard to send or to discharge a patient who is on oxygen therapy. You can still give more counseling and good communication to the family and about the aspect of birth care.
I think one of the things for me is that in the process of the child being assessed in the hospital, getting on oxygen treatment.
Erin, can I say something about
Yeah, of course, sorry.
This is Bull Daniel from Malacan. Hello down. Yeah, this is Bull Daniel from MSF Spain Open Malacan project.
Yeah.
Team together, yeah. So I wanted to say something about the best approach when a family requests to see a traditional healer. You know, here the best things to be done here is to let the family know about the prognosis of the condition in which their child is going through. Right here in MSF Spain, MSF OCBA, we have the form that are designed. Okay, we have a form which read discharge against medical advice. We have it here in the facility. So when we explain to the caretakers and they are not well off with it, or they are not taking our advice, of course we do issue them the form to fill and to sign. This one is used for medical references, as in a way that we do not allow this patient, because where they're taking their child is not where care is what we expect as medical personnel. So that form is what we mostly give them to sign, and when they sign it, then we are a bit relieved, though they are taking to where they expect. You know, with palliative care, most people don't understand. They'll just take it as the end of life, and it's not how we as medical do expect it. So basically, we let them understand the condition. Then if they continue resisting, we can also give them that form that I'm talking about. And it's a little that I wanted to add. Thank you. Thank you.
Thanks.
Yeah, thanks.
I think it's important. One thing, though, I think is important is when we're working in situations where the spiritual leaders have a lot of power and influence over people, we don't want to make a bigger divide between the medicine that we practice and the culture and the beliefs of people around us. So I think it's important to show that because we are saying that spirituality is part of palliative care, it is important for us to look for ways that we can compromise to respect the spiritual traditions and the culture. Because you won't have people coming for palliative care if they go to the traditional healers first, and we're telling people not to listen to that the traditional healers are bad, or they don't, you know what I'm saying?
Yeah, I think especially in this situation, Bo, I personally would probably not recommend the route of having the family sign against medical advice paper. I think as a team, it is really important that we would come together and identify the prognosis. I really liked that point. I think that is really important. And I think as we counsel and as we walk alongside the family, they were in the hospital for 10 days. It's quite a lot of time. I know it's difficult because they had just heard about the diagnosis. They came to an understanding that the child was very sick. But in this situation, I feel like they were able to bring together the wishes of the family for the traditional healing, but also that they understood the oxygen was quite necessary. So they brought the traditional healer to the hospital. They were able to find that the child had, weeks to live, not months and years to live. So they were able to see the value that the family put on the traditional healer. They were able to kind of compromise. The traditional healer was able to come, but ultimately the outcome would have been the same if the child had stayed at the hospital or if the child had gone home. The child was terminal. The child was not able to access a surgery that would have cured the child. So by us instituting, one of the tools that we have is this thing about against medical advice. In this situation, I think it would have created major divides between the family and may have actually continued misconceptions about what the work of palliative or symptom-based care is. I think that family decided to go home so that they could, in a way, the child being at the hospital, continuing to have oxygen. Yes, they were able to improve the child's quality of life for a very limited amount of time. So I think actually, in a way, the child going home and being with the family during that special cultural and religious event of Eid was actually probably the best thing for the family. We can agree to disagree. If you in the field feel that these kinds of tools that you have asking people to sign against medical advice is helpful, then we can definitely keep talking about it. But I think in this particular situation, I think it would have not been helpful. What do you mean about that, Ali? Oh, sorry. Go ahead. Sorry about that. Are you there? Hi, Ellie. Maybe Ali's having a hard time with his connection.
I'm there.
Hi, Alice. Yep. Go ahead.
Oh, okay. Oh, sorry.
Oh, there's rain. Okay, so it's your connection. Sorry about that. Does anybody have any final comments? We're getting closer to the end of our call. Or Esther, do you have any comments about the comment from Bull?
No, I think what you said, I think just recognizing that when we're doing palliative care, it's centered on the patient and the family and what their wishes are, and the context that we're working in and the culture that we're working with is really important. And I like that about this case, that they actually use diagrams and to explain to the family. And they also had people speaking in the native language, but we know in some context, even talking about a DNR with people is not culturally appropriate. Stephen, did you want to say something?
Yeah, thank you, Esther. Gosh, it's a really interesting and helpful case. I've often wondered about this. I agree entirely with signing a DNAR form, or not a DNAR form, a discharge against medical advice in this situation would not be a good idea. I've often wondered, why don't we have another form which, that it says we have discussed the case and we agree together that the child may live a little longer in hospital, but actually it's best for the child to go home with the family. It's all a matter of communication, isn't it? And having it clear that the best for the child has been decided. I'm just interested to know what happened. What do we know? What happened? Did the child go home, and how did the child die? And was there an opportunity to do bereavement care and follow up?
I'm not exactly sure. This is a case from a few years ago, but I do believe that the child died shortly after. MSF does, obviously, in that project, they had a huge mental health team. Obviously, the family got a lot of counseling, so I assume they would have followed up, especially because of the situation of going home, you know, being oxygen dependent. So I assume they definitely followed up, but yeah, I think
terribly difficult. I mean, yeah, it's a matter of compromise and maybe trying oxygen for a while and then allowing the family to take the child home. But I don't think there's any right or wrong, and you've just got to do what you feel's the best with your resources that you have available, and use the right language. Really, thinking of an adult case, I can think of a friend of mine who was very upset with advanced breast cancer, and decided to stop chemotherapy. And she heard the doctor saying, this lady is a difficult patient. And she decided she didn't want any more intensive therapy. So that one comment from that doctor that she overheard really upset her and her family for a long time. So we have to be so careful as to how we handle what we say, and paperwork can be a help, but also a problem.
Yeah, for sure. One of our, Esther, one of the comments in the chat was from Tawane, who is a palliative care nurse in Dadaab refugee camp in Kenya for the last 12 years. He's been doing home-based care. And I think this is really, maybe we'll end today on this comment. Signing a discharge against medical advice is used when you're dealing with curable conditions, but in our case, it was an irreversible condition. So I think that also really helps us to put perspective on that. But let's not stop the conversation here, please. I think these kinds of things are never easy to decide on your own. It's never easy to decide even within your team. So thank you definitely for bringing that up. I think a topic I'm going to write down on my notebook and paper is how do we culturally and sensitively support families when they want to go home? And I think that would be a really interesting conversation to have, especially in places where going home isn't really the best idea. The living conditions are very poor. But then there's also situations where it actually is really the best thing for the patient and the family. So maybe that's a new topic. Buak, I see you have your hand up, and that'll just be the last comment for today.
Okay, I think thanks to Esther for sharing this case with us. I'm worked near a clinical officer working for MSF in Bentiu healthcare facilities. Yeah, we do have a case like what has been shared by Esther, where we had a lot of patients want to go home. But what we normally do is to have the multi-team communication, where we involve the mental health, and even sometimes we involve some traditional, traditional leaders, especially those who can be able to treat the patient. We sometimes have a breakthrough with them, but sometimes it's difficult. They will go home with their child, and then after that, we're following them up through the work of our outreach team working with us in the hospital, where we put down the efforts and to make sure that we follow them up in their respective places where they are going. But it's one of the challenging actually case that we do, but we don't give them a medical advice or a discharge against medical advice, as my colleague said. But what we normally do is to grant them their request, because these are people who might have stayed for long in the hospital. And then if you will tell them, okay, I'll give you a medical advice, it will be very bad for them. They feel very horrible, and they will not even they will not come back in case the child condition deteriorated at home with them. But sometimes they do come back alone willingly, not with follow-up. Yeah. What I can just say is that it's just a communication, and we will not give up. We keep on talking to them even to where they go to the destination. Thank you.
I think Boak, I think you're going to be the next presenter of this case next time. We'll have to connect. Where are you working again? In South Sudan or Kenya?
No, I'm working in South Sudan.
South Sudan,
Bentiu, South Sudan. Yeah.
Thank you so much. Thank you so much for that. Esther, you have the final word. In Kenya, we often pass the microphone around to whoever has been an inspiration. So it's on to you for the last word of today. And just a reminder, please sign the attendance sheet. And next week, we'll be talking about trauma-informed psychosocial support. And we'll be having a social worker speak to us. So Esther, final comments, and then we'll turn it off.
I just wanted to say thank you to everyone for their participation today, for the courage that they must have working in the situations where they're working. And I wish you all hope and peace and continued courage to do the great jobs that you're doing, and looking forward to learning more with you in the future.
Thanks a lot, everyone. We'll see you on Tuesday next week. Bye-bye.
Thank you.